So in this lecture, we're going to go through the immunoproliferative diseases where the immune system is triggered to overreact or overact, either continuously, chronically, or in an acute stage. So of course we know about the two. You've studied these, so obviously important at MSK, but leukemia and lymphomas are two important types of immunoproliferative diseases. In leukemia, you have some form of malignant cell. Primarily, you find them either in the bone marrow or in the peripheral blood. Whereas in the lymphomas, you have a malignant cell that arises in lymphoid tissue. So your lymph nodes, which like include your tonsils, your spleen, that kind of lymph tissue. Okay, now obviously there's going to be some kind of overlap between these because it's immune cells that are fostering these changes that are occurring in this, and there's so much connection between all the different immune cells that you can see that there's definitely going to be some overlap, especially as they become more and more advanced. Then we also have to add into this group are the plasma cell dyscrasias or disorders. The major ones for here is multiple myeloma and the Waldenstrom's macroglobulinemia. Oh, I misspelled macroglobulinemia here. I apologize for that. But these are biologically distinct. They're not as the same as a leukemia or lymphoma. They are distinct from the other two, although clinically they might seem to share some serious, characteristics. They do commonly involve the bone marrow and the lymphoid organs, but they also, there are other non-lymphoid sites that are involved. In this case, the plasma cells, they may be found in the peripheral blood late in the course of the disease, but early on you wouldn't necessarily see them there. Now, each of those include an area that you already learned in immunology called transformation. When your cells, the genes within that particular cell, have changed enough to cause those cells, which remember, they're already cells that are actually meant to proliferate, but they don't respond to the normal checks and balances anymore, where proliferation should end. So when you have a malignancy, you have an excess production of the cells, usually through rapid proliferation. And with rapid proliferation, we don't normally see the maturation. So there's some point in that transformation where maturation has been abandoned. In the other situation, you can have normal proliferation of the cells. They continue to grow, but there's no apoptosis. There's no end to that. So there's two stops to proliferation, either the normal, signals that should stop it. Here for my little marker. So when you have the cancer stem cell theory, which I think most people think of cancer as, you have one a small population or a single cell that becomes transformed. So the genetic material is altered so that it either doesn't respond to inhibitory signals or it produces such a large growth signals that it overcomes them. And that leads to, from that single cell, that leads to a tumor that all arise from that single cell. That's one theory. Then we have the stochastic cancer model, where this isn't really about stem cells per se. All the cells that are produced, they're normal cells, right? They keep being produced. There's nothing particularly, they can respond. But in this particular case, no apoptosis occurs, so the cells continue to proliferate and to last into the future. Not really what we intended. Now, remember, these are cells that are particularly sensitive to this. Why? Because these cells, immune cells, lymphoid cells, certain leukocytes, they're meant to respond to a stimuli by proliferating. That's supposed to happen. But when you're talking about a malignancy, you see that there has to have been some kind of lack, some kind of failure in regulation of that proliferation, or in the steps in maturation. So proliferation usually is accompanied by maturation, and that doesn't usually happen in these kinds of tumors. And the reason for that is there's some kind of altered or abnormal gene, and those are required. You usually have to have more than one altered or abnormal gene in order for transformation to occur. Now, this is not sufficient for complete transformation. It will be there for some form of transformation, but not for complete. Remember that development of cancer includes many steps, and so gene alteration is only one of them. There are other steps that have to occur along the way, and that's part of the staging and things like that. How altered are the cells? Now, the other thing is that you have many immunologists and microbiologists who believe that these alterations are generally triggered by some stimulating event. And of course, if it's a microbiologist, infection is the thing that comes to mind for me, but there could be other proliferative stimuli, especially considering it's the immune system. And you have antigens that are capable of generating a response from the nuclear material. So depending on, sort of your perspective, you might favor the infection over the other stimuli, like me, but that's just, a perspective. Either one of them is capable of causing that kind of stimuli, that kind of triggering event. So because these cells should proliferate, these cells, the lymphoid lines, these cells are definitely at greater risk for transformation, and hence we see these kinds of cancers a little bit more commonly than other cancers. And there are various, and you could see that with other cell types too. The faster the cell type is intended to proliferate, the more it's supposed to proliferate, the higher the risk that transformation can occur. Okay, because it's kind of primed for, uncontrolled division. Now there are various theories, tons of theories about how transformation occurs, and we're going to go through a couple of them here. One of them is with persistent immunostimulation plus some kind of immune deficiency. So immunostimulation can be anything. Constant, and this is something that most the news media and stuff, they're kind of on the line with this. So immunostimulation, constantly offending or, triggering your immune system, whether it's by, we know that tobacco and smoking causes a higher risk of cancer. Well, you're actually inhaling on purpose all kinds of foreign things that are highly immunogenic. So that could certainly make sense. You have persistent immunostimulation. And then if you add to it, so this is plus, some kind of immune deficiency. Not everybody develops cancer, so there must be something else involved. And some kind of immune deficiency, maybe a loss of regulation, whether it's temporary or chronic, this could happen, and it could again prime the situation so that you end up with some kind of tumor growth. Okay, that's probably the one that most people are familiar with, we'll say. Okay, even if they're not really sure that that's how you would word it, that's probably what they're most familiar with. The stimulation that occurs where, in the case that you have deficiency, that deficiency could be any number of things. You're not able to clear the stimulating agent, whatever it is, so that's going to even cause stimulation to continue, and you'll also get the inability of the immune system, whether it's T cell inability to clear those annoyed cells, inability to regulate those stimulated cells, whatever the case is, it could potentially lead to at least part of the transformation. With the clonal hypothesis of malignancies, the theory is that all malignant cells will arise from a single identical line, and here's your single identical line. And that was given some kind of survival advantage by its transformation. So maybe it's ignoring or able to resist immune suppression. And so those malignancies, according to that theory, they would be classified based on the clone type from which it arises. So this is the theory that if I develop cancer of the lung, and then all my future tumors are related, potentially, any future tumor, any cells within that tumor are related to the initial cell, the initial clone, that was transformed. So these are the two, you see the difference here, persistent stimulation or the clonal hypothesis. There's probably definitely some correlation between the two. Okay. There is also, as far as the things that can cause it, there are specific genes that we know for a fact are involved in transformation, and those genes are called oncogenes. Oncogenes are actually usually viral products, which have been able to interact with host proto-oncogenes, which are the genes that you carry. Okay, so you carry genes that if they come in contact with these viral genes, they can cause dysregulation and possible transformation. Again, it's a one step. There's several other things that have to happen in order for that to happen. An example of a proto-oncogene that you normally carry, it's in your genome, is the c-Myc gene. That's a normal gene. It's involved in regulation of cell growth cycle, and normally c-Myc will be stimulated when proliferation is supposed to occur, but then it's supposed to decrease, right, when you get the suppressive signals. In certain lymphomas, for example, Burkitt's lymphoma, we can demonstrate, or by we I mean researchers have demonstrated, failures in the c-Myc regulation. Now this is associated with oncogenes that are contributed by EBV. So EBV, Epstein-Barr virus, contributes genes to your genetic material, or it produces a product that affects your genetic material, so that c-Myc is overstimulated and underregulated, and so you get tumor growth. Again, there's other things that are also necessary, otherwise everybody who has EBV would be at risk, but not everybody who has EBV gets cancer, gets Burkitt's lymphoma. Okay, so there are other things that have to occur at the same time. Other things that can stimulate transformation are gene translocations. Now these gene translocations occur when you have a portion of one gene transferred or switched with a portion of another gene. And there have been certain lymphomas, follicular lymphomas in particular, that frequently have a translocation between 14 and 18. And this will cause, if it's done right, it will cause a rearrangement of the gene BCL2. That rearrangement causes BCL2 to be just absolutely completely overexpressed. It's just always expressed once it's rearranged. There's no inhibitory mechanism to stop it. And that increased BCL2 will upregulate intermitochondrial membrane production, which, step by step, will block apoptosis. So these cells, if we go with the first model here, these cells aren't exactly proliferating if they have this BCL2 rearrangement. However, they're not dying when they're supposed to. So you end up with these little small cell lymphomas that have these transformations the cells keep growing and growing, and it's not that it's kind of more of a chronic situation where you gradually see an increase in these cells, not because they're really dividing faster, but because they're never dying. Okay, so no apoptosis. So remembering which ones have which. So Burkitt's lymphoma, you're talking about the oncogenes with EBV causing interfering with the c-MYC. We also do see a c-MYC translocation that can occur with Burkitt's lymphoma between 8 and 14. And then we also can see a translocation with mantle cell lymphoma, and that's for the BCL1. That's frequently between 11 and 14. There's definitely a number of translocations that are present. Sometimes you see both the oncogene and the translocation. Again, step by step. Does the oncogene cause the translocation? These are all things that researchers are working on. Now, the lymphomas themselves are going to be divided into either Hodgkin's or non-Hodgkin's type lymphomas. And there have been many schemes used to classify the various. Mostly it's the non-Hodgkin's that the classifications have changed. So in the 80s, they used this working formula classification, which was based on the architecture of the lymph node. So it was really heavily dependent on cytology. Cytology, which would be you'd have to worry about light microscopy, staining procedures, things like that. It didn't consider necessarily the T cell or the B cell lineage. So it would separate the lymphomas into these low, intermediate, or high grade processes based on the aggressiveness. So you needed clinical information, you needed cytology information. But it was the 80s, okay? That's kind of the technology that we had at the time. So as technologies have improved, some of the classification schemes have improved. So in the 90s, they developed the REAL approach, which is the revised European American Lymphoma classification. And this actually defines the lymphoma by cell origin. It includes morphology. So cell origin really relies a lot on your flow. Okay, get the information that you get from flow, but then don't leave histology out. We're still looking at morphology of the cell and the immunophenotype. Again, flow, we need that. Then we look at genetic features and clinical features as well. So there's a lot to take into account with this particular classification scheme, okay? So it will divide your non-Hodgkin's lymphomas into neoplasms of precursor cells and neoplasms of mature T or B or NK cells, depending on which they are. So it really relies on which cell is starting this, which cell started the trouble, okay? So this is kind of one of the classification methods that's out there. And then look over here, I have the little, WHO always wants to get itself into the fun. And so this has classification of neoplasms. You have your B and your T cell, non-Hodgkin's neoplasms, in your Hodgkin's disease is smaller list. So, but you can see the list is large, and it relies on, you've got a whole bunch of different cell sources, and you still have to include things like morphology, things like the clinical features that are around. And this will probably change as more information becomes available as we go into the future. I wouldn't be surprised to see it change a lot from year to year and a lot faster as our technology improves. Now, the Hodgkin's lymphomas these are the highly treatable, often curable lymphomas. Again, if you have to have one, you'd rather have a Hodgkin's over a non-Hodgkin's. And there's some things that we see that are sort of left over from when we had less technology, more staining, and morphology things, and some classification features which they use still. They'll go forward and they'll look for, flow characteristics and stuff like that. So one of the classic things I'm sure you've heard of, and we talk about it because it relates to us in the lab, are the Reed-Steinberg cells. Now, we have to know about these, although the Reed-Steinberg cell is not going to be seen by you. It's going to be seen in histology, right, in cytology. But this is a characteristic cell, classic cell, that you would see in a preparation in a slide formed from a lymph node of somebody with Hodgkin's lymphoma. And this is how they describe it is the owl eyes. So you want to see this over cell with the two large internal structures, which is referred to as owl eye in appearance. And you can see this is great picture here. They don't always turn out all that great. You can see the Reed-Steinberg here, a little less owly looking, but it's still there. Looks kind of like a scream mask or something like that. But you have to remember what the Reed-Steinberg cell is associated with, okay? And generally, with the Reed-Steinberg cell, you're talking about a B-cell lineage. That's what we're referring to, okay? But the main thing these days, what they really want to be able to do with Hodgkin's is to differentiate between nodular lymphocyte Hodgkin's and classic Hodgkin's, okay? Classic Hodgkin's is subdivided into four groups. We have the lymphocyte-rich. That's a small percentage, only about 5% of the cases. The nodular sclerosis, this is the most common subtype. About 70% of the patients have nodular sclerosis, where they demonstrate an infiltration of mixture of normal macrophages, lymphocytes, and granulocytes with a small number of Reed-Steinberg cells. And it's nodular sclerosis because there's a marked level of fibrosis in those lymph nodes, okay? Then we have the patients who have classic with mixed cellularity. In this one, you have a mixed infiltrate of normal cells with a greater number of Reed-Steinbergs. And this is about 25% of the cases that are out there. So there's less sclerosis in this. So the cell types that you would see would be the same as nodular and mixed, but the percentage is different. So with a larger number of infiltrates and less Reed-Steinbergs, you call it nodular sclerosis. Also, they have marked fibrosis. Less fibrosis and a more even mixture is mixed cellularity. Again, that's only about 25% of the cases. And then our last bit are the lymphocyte depleted. In this case, the lymph node demonstrates diffuse fibrosis and relatively few infiltrates. This is the part that has the greatest number of Reed-Steinberg cells. And unfortunately, lymphocyte depleted Hodgkin's has the worst prognosis of the four within classic Hodgkin's. So compared to the other four, you don't want the lymphocyte depleted, okay? You don't want any of these, really, okay? Now, the Reed-Steinberg cells in all of these types, they all have the same or a similar immunophenotype, okay? So meaning if you do flow on these Reed-Steinberg cells, you're going to get about the same thing. All of them should be CD30 positive. So a Reed-Steinberg cell should be CD30 positive. And about 80% of them are CD15 positive. So not uncommon to get CD35 and 15 positive. But at the same time, you should have either weak or no expression of CD20. Okay, so those are the three markers that you're looking for to classify it by flow as a Reed-Steinberg. That's CD30, 15, and 20. Those are the ones that you're going to be looking at. First two positive, usually, and the CD20 is either weak or absent. Now the nodular lymphocytes, nodular lymphocyte or nodular Hodgkin's, this is different in the morphology than those found in the classic Hodgkin's. Okay, it's referred to as lymphocytic and histocytic cells. Okay, these ones, their expression is different. These rarely express CD30 or 15, and they express the 19 and the 20. 20 is the one that we refer to, but 20 they do express. So where 20 is usually absent on the Reed-Steinbergs, here in nodular lymphocyte, we do see 20. In addition to, we see CD19, and we don't see CD30 or CD15. Okay, so the cells that we see in the different preps that we get will have different expressions if they are classic or nodular. So you have to remember those markers because, oh, that's where we're going. And okay, yes, the Reed-Steinberg cell is lovely to see, and we want to know about mixed granularity and all that fun stuff, but really it's the markers. They provide us with a much more objective measurement of what kind of Hodgkin's we have here. Now, the other thing to remember, and that should be tested on all patients once a lymphoma is discovered, is EBV. Patients with Hodgkin's will have increased EBV antibodies. Now, the actual connection, although it is very strong, has not been, completely tied in really tight. So it's still called an association, but it's a very strong association. We do see increased antibody levels in these patients. The non-Hodgkin's lymphomas are definitely a much wider range of neoplasms. We definitely have a lot more issues that we have to look at when we're trying to characterize, classify a non-Hodgkin's lymphoma. By far, B-cell lymphomas represent the majority of cases. About 85% of the cases of non-Hodgkin's are B-cell lymphomas. The most common of those being the diffuse large cell B-cell lymphoma, about 30 to 40% of them. And they can be divided into three broad groups, and it's based really on prognosis. The low-risk group, which includes things like the chronic lymphocytic leukemias and lymphomas, the follicular lymphomas, and the MALT cell lymphomas. Those are all in the low-risk groups. Then we have the intermediate risk groups, including diffuse large B-cell lymphoma and Burkitt's lymphoma. And then the high-risk groups, which would include the mantle cell lymphoma and the lymphoblastic lymphoma. Now, we can see, just because we've diagnosed the cancer doesn't mean it's done transforming, doesn't mean the changes to its DNA are done happening. We're trying to kill off those cells and hopefully we'll be successful, but the reality is those cells are still changing if they have the opportunity to. And so as the cancer develops, it can actually become more aggressive over time. And change in its expression, and that process is known as lymphoma progression. Now there's three characteristics usually identified in lymphomas that help it to identify it as B-cell in origin. Obviously, surface immunoglobulin is a pretty good clue, okay? There are no other cells that have surface immunoglobulin. They also have certain surface proteins that are unique to B cells, like CD19 and 20. Those are specific and sensitive for B cells. So if we see CD19 and 20, that's a pretty good sign that we've got a B cell lymphoma here. Then the other things that we can look for are those rearranged immunoglobulin genes. So no other cell would have a reason to rearrange those. So that's a pretty good way to be able to identify this cell type as a B cell, or originally as a B cell. It may not look like a B cell much anymore on the outside, but we have those markers on the inside that we can look at. There Well, okay, so there are some B-cell lymphomas, like for example, small lymphocytic lymphomas. These will originate from these small lymphocytes. And those are the ones, the immature ones, that are usually waiting for their first encounter with whatever their antigen is. They're generally indolent, but they can be inexorable diseases which are compatible with survival for up to a decade. So the patient can live with these chronically. Unfortunately, they can progress, and that's what we're talking about, lymphoma progression, to a pro-lymphocytic leukemia in about 10 to 30% of the cases, or to a large cell lymphoma or some other aggressive lymphoid malignancy. Again, we're talking somewhere between 10 and 30. The really aggressive ones, only about 10 to 15%, relatively low, but it's not zero. Okay, and that's the thing we're trying to prevent for our patients. There are other B-cell lymphomas, like, for example, diffuse large cell or lymphoblastic lymphomas. And these will actually, instead of deriving from the immature cells, these derive from rapidly dividing cells. Okay, so now normally B cells will proliferate at two different stages. The first one early on, when they just emerge from the bone marrow. Okay, they brand new cell, they're going to make more copies of themselves, but they haven't encountered their antigen yet. And then later on, after they encounter their antigen, it is possible that they can, or they should proliferate again. And their lymphomas can be tied to either of those proliferation stages. The ones that are tied to the later on, to the later stages, tend to be much more aggressive and can lead to death really in less than a year if they're untreated. Okay. Now, where B cells, we have pretty clear markers and they're fairly, obvious to identify. B cells are B cells. There's not a lot of subtypes of B cells. T cells, however, much more difficult to characterize. And part of the reason for that is there's so many different T cells, okay? There's no easy way, we'll say, to assay the clonality of a T cell like there is for a B cell. B cells, they express immunoglobulin. They have a light chain on their surface. Pretty easy to figure out, oh, this is a B cell. T cells, it doesn't work that way, right? You have Th2, you have several subgroups of T cells that make it difficult to identify their original clonality. Plus, there are a number of T cell syndromes that are able to sort of progress in a really stealthy mode from atypical but non-clonal into clonal proliferations. So they kind of sneak their way into, and T cells are meant to proliferate as well. So because of the difficulty with T cells, we can't just use their morphology. We have to use other methods to help us classify them. Molecular techniques definitely help if we find rearrangement of the T cell receptor gene. That helps. In benign T cell malignancies, we usually see slightly different rearrangements in the populations, whereas malignant populations have a uniform rearrangement throughout the malignant population. Okay, so that's one way they help to identify the aggressiveness of the T cell lymphoma. Also can use flow cytometry. Obviously, we like to use that because it's either it's expressing it or it's not, at least for now. And if you have a suspicious population, that what you're looking at you're looking for the T cell markers that should be there, but are not there. So you're usually looking for some kind of marker that's absent on a T cell. You think it should be a T cell, but the markers are absent. So so if you look here in this the T cell table here, you can see some of the markers that are tested for when a T cell lymphoma is suspected, and you can see which diseases either express or do not express. So if we look here, adult T cell leukemia lymphoma expresses CD3 and CD5, but not CD7. It may or may not express, and whether it's plus or minus, so may or may not or may, so you favor one or the other. CD4, CD8, and CD30, those are classic T cell markers. Then look at some of the other ones. Is NK16 or 56 there? Does it have cytotoxic granules? And is the CTR, which T cell receptor is expressed? Those are all things that we can test for using flow. The lymphoblastic leukemias, these are very broadly classified as either acute or as chronic, which while it sounds like you'd rather have chronic disease because they're slower and it sounds like, well, I could deal with it, I'm strong, you know. Generally, chronic ones are much more resistant to treatment. And while the acute ones are definitely more aggressive, they tend to respond better to the treatments that we have. So I wouldn't probably want the chronic if it just means a slow decline. Now, the acute ones include ALL, which is acute lymphoblastic leukemia, and this is very poorly differentiated precursor cells that are present in the bone marrow and in the peripheral blood. And they can end up infiltrating all kinds of soft tissues, leading to organ dysfunction because they're just sort of creating these little groups everywhere they shouldn't be. Okay. Now this one, remember, ALL generally seen in kids, and it has a pretty good remission rate, 90%, with a cure rate of 60 to 70%. Much lower rate seen in adults. Immunologically, for our purposes, it will be divided into 4 groups. You have CLL-A, which is a CD10 expressing immature B cell. That's the parent cell. Then we have our pre-B cell ALL without CLL-A, meaning without the CD10. We have our T cell ALL and our B cell ALL. Okay. If we move then to the chronic lymphoid leukemias or lymphomas, these are almost exclusively B cell in origin. Okay. These include chronic lymphocytic leukemia, small lymphocytic leukemia, pro-lymphocytic leukemia, and hairy cell leukemia. These are all chronic leukemias or lymphomas. And these are considered, while the CLL and SLL, they're considered a single disease by the WHO. They do have different clinical presentations, so they probably, while the WHO may find that useful, clinicians might like to look at them as separate disease. However, what do they have in common? Both of them the cells express CD19 with weak expression of CD20. And then hairy cell leukemia, this is a rare, slowly progressive disease where we see infiltration of the bone marrow and the spleen with these leukemic cells, but there doesn't seem to be involvement with the lymph nodes. Generally, the patient's going to present to you with some kind of cytopenia, but the blood lymphocyte count doesn't necessarily look it doesn't have to look particularly high. What really is striking in these cases in particular is the splenomegaly. The patient probably has a very large spleen. And the lymphocytes that we do see they have this irregular, hairy presentation, which are really just cytoplasmic projections, but it makes for a memorable name. Okay, so how do we identify these? Using flow. These cells, the hairy cells or the leukemic cells for this, these strongly express the CD19, the CD20, and the CD22. Okay. Characteristically, so we're still using our our cytology laboratory, histology laboratory, and they're still doing their stains. And so the hairy cells these usually contain tartrate resistant acid phosphatase in their cytoplasm. It's another way that we can identify these cells specifically to be able to classify this particular anemia. Then we have the plasma cell dyscrasias. Okay, so while these can be either benign or malignant, they generally do result in hypergammaglobulinemias. Okay, the key thing is that they're usually characterized by some kind of overproduction of usually a single immunoglobulin component, not necessarily a full immunoglobulin. So, for example, we classify the myeloma protein or the M protein or a paraprotein. So it's something, it's not normally supposed to be produced at that level. So those are the hypergammaglobulinemias. When you have a monoclonal gammopathy, like for example, multiple myeloma or Waldenstrom's macroglobulinemia, any of those, these you have a single clone or a single B cell, which is overproducing and just keeps producing the same immune factor. So that's why it appears as a single spike on the electrophoresis. Compare that to a polyclonal gammopathy, which is generally a secondary disease, and it'll demonstrate an elevation of 2 or more immunoglobulins by several different clones of plasma cells. So what starts as a monoclonal gammopathy can progress to a polyclonal gammopathy, potentially. And these are just the symptoms of each of the monoclonal gammopathies. A nice little chart to show you. You have the multiple myeloma, the smoldering myeloma, the solitary plasma symmetry of the bone, and the monoclonal gammopathy of unknown significance. Again, what do they look like? Polyclonal versus monoclonal. It's really referring to the electrophoresis. Okay, so when you have a single clone, so elevation of 1 here, 1 is, but everything else is decreased. So here's your normal. 1 is elevated, everything else is decreased. Okay, so you elevate 1 to the detriment of others. Whereas in polyclonal, we've got several increases here. Okay, it's usually secondary to some kind of infection or inflammation. So you can see polyclonal gammopathies, not just, it doesn't necessarily have to be malignant, it could be associated with some other non-malignant disease, some kind of chronic infection, liver disease, hepatitis, and rheumatoid connective diseases are also capable of producing this kind of pattern. But included in the list is what we're talking about now, lymphoproliferative diseases. Okay, so multiple myeloma specifically is a proliferation of a single clone of plasma cells producing a specific type of immunoglobulin referred to as M protein or myeloma protein. The other word for it is paraprotein. So that actually, what that consists of is 1 heavy chain and 1 light chain of a particular class. Okay. The cause of multiple myeloma, they don't know what the stimulating factor is, but it is the most common form of plasma cell dyscrasia. Okay, it is estimated that we diagnose about 4 cases in 100,000 annually, with about 10,000 deaths annually. Unfortunately, while the onset is not very clear, between 40 and 70 years old, that it is generally considered something, a disease of the older. The peak incidence is closer to 70 than it is to 40, okay? And IgG is the most common form of multiple myeloma with the 4 subtypes, and those subtypes are based on the class of IgG. Is it G1, G2, G3, or G4? The most common subtype is the G1, 65% are IgG G1 subtype, followed by G2, then G3, and then G4. So they're in progressively lower and lower percentages. This runs a very progressive course with most people dying in 1 to 3 years. So it's fairly, I would say fairly quick progression. And the key symptoms include bone pain, in particular in the chest or in the back, along with weakness and fatigue. You could have some paleness associated with anemia, even including some abnormal bleeding. There'll be some liver enlargement, a little bit, so rarely you might have some spleen enlargement. Most patients will have some destruction of the skeleton, which is really what is causing the bone pain. And they'll have these like punched out or lytic areas, and you can see it here on this x-ray of the skull. You see these, the bone is starting to look like it's, got gray areas, it's got pocks or something like that. Those lytic areas are really areas of both osteoporosis and it can include fractures, where basically your plasma cells are just causing havoc, okay? You will see plasma cells in the bone marrow, increased plasma cells in the bone marrow, and you can see that here in this picture, and even potentially in the peripheral blood. What you'll see for the rest of the lab, there'll be qualitative, maybe quantitative, but definitely qualitative platelet abnormalities with definite inhibition of coagulation factors. That inhibition is actually run by M protein. It actually causes interference with the coagulation function. And the platelet abnormalities can also be, again, like I said before, usually a little bit later on in the disease, but you may have thrombocytopenia, and this is when you have the highest risk of DIC. So because of the qualitative platelet abnormalities, and then you have so few of them, you can get coagulation and DIC occurring. You can also get renal failure. Again, you get those M proteins building up in the small capillaries. It's a major problem, especially after an infection, okay? Hypercalcemia is a big issue, as well as dehydration. Chronic renal failure, much more common than acute renal failure. Again, the acute renal failure is usually associated with an infection of some sort. Chronic renal failure, it's these M proteins clogging up the works over time, okay? This would usually be signified by an increase in your serum creatinine levels. It'll start going up above 1.5 milligrams, and you'll start to see those. You're also more likely to see renal failure with a certain M protein. So if you get an IgD or a light chain myeloma, these are much more likely to cause renal failure than those who have an IgG or an IgA myeloma. Interesting. Reason why? Nobody knows. Or, well, they're guessing on it. Remember, Bence-Jones protein will be present in the urine. That's the light chain. And you'll see those renal tubule defects that occur because of the issues going on. It's really secondary to the issues going on in the rest of the body. The most common cause of death in these patients actually is infection. The overall immunity is so poorly run that the slightest infection could really lead to death. And these are patients who are older, right? 70s. That's your peak incidence in the 70s. So a patient who's 70 has a higher risk for pneumonia anyway, and a patient with multiple myeloma, it's much more likely to kill them. Now, immunologically, these cells, multiple myeloma cells, are going to express cytoplasmic immunoglobulins, which is normal on plasma cells. Plus, they're going to express your B and your T, your NK and your myeloid, and you're going to see all of the other cell markers. These are probably transformed pretty early hematopoietic progenitor cells. They might be present, and the major growth factor for multiple myeloma happens to be interleukin 6. Patients with multiple myeloma have several defects in their humoral immunity, but not in their cellular immunity. Okay, so while they have increased susceptibility to bacterial, like bacterial pneumonia, they don't really have increased susceptibility to fungal or viral infections. Again, pneumonia will likely kill them, but it'll be bacterial pneumonia, most likely will be bacterial pneumonia, not necessarily like the flu or something like that. You will see a reduction in the CD4, your helper population, and an increase in your CD8, which is your suppressor population. They're trying to calm down the rest of the immune system, but unfortunately with multiple myeloma, it's a difficult one to get a handle on. You'll also probably see anemia. Again, the entire bone marrow is affected, and in about 2/3 of the patients, you'll see a normochromic, normocytic anemia with rouleau. Obviously, we know that. There's definitely rouleau in these patients because there's so many proteins. So this slide just gives you the, some relative examples of what the various, species of myelomas can be. So you have your normal serum here, overall macroglobulinemia, so you have your IgM peak here. But we look at each of the myelomas, IgE, D, A, and G, and you can see where the peak is and the relative amount. Remember, there's overall more IgG anyway, so a peak is going to be much higher than the relative increase in IgA. But you could see where the peaks move, and that when you are overproducing IgG, in this case, you see that other peaks suffer, and that's pretty common for myeloma. So you should be able to differentiate the types of myelomas from each other. So then there's Waldstrom's primary macroglobulinemia. Okay, this is a malignant lymphocyte plasma cell proliferative disorder where you have an abnormally large amount of IgG, of immunoglobulin of the IgM type. It's a so mostly what you see in this particular case is overproduction of IgM. In the particular type, it's a 19S IgM. You don't really need to know what type, but that it is IgM. It is, there is a genetic component to this, or a possible genetic component to this, in the sense that there is a rearrangement associated with it. It's an 8-14 and rearrangement and a trisomy 12. So those are two chromosomal aspects that are associated with this particular, not necessarily in every single one, but they are much more highly associated in this particular disease than in others. We usually see this onset somewhere between, early 60s is when we see them. That's the mean age or the median age of onset. And it's usually an insidious onset, so slowly progressive. But the median survival after diagnosis is 3 years. So it takes a little, it's not an acute onset. But then once it's diagnosed, it's pretty, I would consider 3 years rapid. Okay. What we mostly see in this is the cold agglutinin accumulation. That's our biggest clinical feature. that we see. The patient will have Raynaud's, they'll have arthralgias, purpura in the extremities, renal insufficiency, peripheral vascular occlusions. There's all kinds of things that go along with it. All of those vascular occlusions can cause not just the renal dysfunction, but also vision changes and neurologic changes, as well as cardiovascular issues. The plasma becomes like thicker, so that could change your blood pressure. And the strain on the bone marrow can lead to an anemia. It is normochromic. It'll be slightly it's normocytic. It'll be slightly hypochromic, a little bit hypochromic. And the anemia it's kind of a dilutional anemia. It's not that your bone marrow has given up producing red cells. It's that they're producing so many white cells that the red cells are kind of pushed to the outside, kind of relatively diluted. So the patient themselves is going to experience the things that you would experience when you have anemia. Okay, they're going to have weakness, they're going to have fatigue, but also some of the other things that you would associate maybe with a leukemia, weight loss, increased incidence of infection, because even with all this great immunoglobulin, yeah, they're not as functional. So infection rate is about 2 times the normal rate. And then the rest of your immune system is trying to clear this stuff out. So about 40% of the patients still have enlarged spleen, enlarged liver, and lymphs as well. The difference between Waldenstrom's and multiple myeloma, you're almost never going to see bone pain in this particular case. They may have osteoporosis, but you're not going to see those lesions that we saw with multiple myeloma. But because of the anemia, the chronic anemia, you're going to have some bleeding episodes, some bruising, that kind of stuff. Your platelets might be normal, might be decreased. It depends on the extent of the marrow insult. Platelet function is definitely altered. And you do also have rouleau formation, okay? So, pardon me. You can see in the bone marrow, you're going to have lots of plasma cells, both, functioning plasma cells. They're just, spitting out IgM, and those that really aren't doing much of anything at all. Other monoclonal disorders that are out there. We have light chain disease. This is about small percentage, about 10 to 15% of your monoclonal gammopathies. And in this case, the patient produces only one light chain. So they produce either kappa or lambda or Bence-Jones. Okay, they don't produce the entire complement because they're overproduced. So they keep trying to churn them out. Because they're overproduced, pardon me, even with the overproduction of these chains in this light chain disease, they still produce very little in total. And so in order to really see this, you wouldn't see this on regular electrophoresis. You do have to use high resolution, or the agarose has to be high resolution in order for you to really see this on the protein electrophoresis. And so the procedure is called agarose high resolution protein electrophoresis. And they do it on both the serum and the urine. You would do a 24-hour urine specimen in order to see that. And what you end up seeing is these casts that are produced this is in the tubules of the kidney. Oh, my brain. In the tubules of the kidney. And so for what would that look like when it got to the urine, it would probably look like a hyaline cast. It might be granular if there's an infection, if there's some other comorbidity with it, but it'll probably look like a lot of hyaline casts. Heavy chain disease. Heavy chain disease, also known as Franklin's disease. In this case, what we're overproducing is the heavy chain portion of the immunoglobulin molecule. You can produce alpha or the beta. The alpha chain is the most frequent type. I'm sorry, alpha or mu. You have alpha, mu, delta, epsilon. Pardon me. And gamma. And so alpha is the one that's most frequent. Mu is a little bit rare, is actually the most rare, and the others sort of fill in the space in between. If the physician suspects this, then you can actually use a non-specific antigen binding fragment antisera, or FAB antisera, and there would be plenty of those. Okay. But you would have to retest that with antisera directed against both the kappa and the lambda light chains so that you can make sure that you didn't have any of those. Plus, you would need to dilute it because you produce so many of these that you can frequently get a prozone effect with these. So you need to make sure that you both dilute it and use the FAB antisera. I'm sorry, you're using that, but you're also going to use a light chain in order to ensure that you don't have something else here.